we will go directly to our next speaker, Dr. Rajesh Chandra Mishra. I hope I am pronouncing the name rightly.
Yeah.
Dr. Rajesh, he has MBBS and MD in medicine. He's a fellow of the National Board in Critical Care Medicine. He has a European Diploma of Internal Care Medicine. He's a fellow of the American College of Chest Physician. He's a fellow of the American College of Critical Care Medicine. He's a consultant intensivist and internist in Ahmedabad in India. He's a Khyati multispecialty hospitals in Ahmedabad. He is now, I don't know since how long, but newly appointed as a president of the Indian Society for Critical Care Medicine. And I would like to congratulate you on this. And now we know somebody very important in India, so we can come and attend your meetings. He's a chancellor of Indian College of Critical Care Medicine, and he's a managing trustee of Critical Care Society in Ahmedabad. And he's a national representative of India in the European Society of Internal Care, of Intensive Care Medicine. Dr. Rajesh Mishra is going to talk to us about managing the difficult airway in ICU patients. And we are really looking forward to hear his excellent presentation.
Thank you, Dr. Sarabi, and thank you, Dr. Saad, for this kind invite. And one of the very important subjects, very close to my heart, because one of the important factors in contributing to the mortality and morbidity in ICU patient, and the incidence, prevalence, and the incidents are very high in if the total care or a bundle or a specific approach is not being followed. So we are very quickly going to look a little bit about the airway in adult and pediatric setup, and then we are going to find the cause of difficult intubation, which will be like in our setup, it will be difficult, different from what routinely say in anesthesia table. We're just going to learn a little bit about the goal of intubation in ICU patient, and then how we manage or what expectation we have for this difficult airway in ICU patient. So the upper airway anatomy, which you know much better than anybody else will know, but for ICU, it is not the only anatomy. The physiology of upper way and lower airway also important, because it's a physiological change which causes the contributes to the maximum problem during intubation in ICU patient. All the ICU patients, one of the key problems are that they have got very low physiological rhythm, they are in distress. So practically every patient in acute respiratory failure who comes to ICU or who needs intubation, they pose a challenge as difficult airway because they do not have a reserve, they do not have a time to break, and do not have indefinite time to find airway and intubate. And that really puts us in a challenging situation. Little bit of difference between the difference about the pediatric airway and adult airway. What we need to know that the shape of the pediatrics and neonates are in funnel shape. They have larger tongue in comparison to their space of mouth. Their pharynx is smaller, and even the tracheal rings are very small. And that precisely reason we need to know the age and what kind of tube they need. Most of the time, these patients need not cup tube, but we have to always be ready that neonates or pediatric age group can present to you with a special challenge. I personally do not practice pediatric intensive care, but we all must know because many times you can come across a child who are younger patient who needs intubation. So a little bit of anatomy we must know. The biggest challenge which we face in ICU, either by induced sedation or when patient is distressed or drowsy, that a physiological airway obstruction due to the loss in muscle tone, and this leads to a kind of choking sensation and hypoxia. A very simple measure, just lifting the chin or opening the airway, relieve this obstruction, which all must know, keeping in mind that if this patient has cervical injury, you have to thrust the jaw out, and if there is no cervical injury or there is no trauma, then you can just lift, open and lift it. You can always put airway, keeping in mind if patient not having coagulopathy or not breathing very smoothly, keep the airway open if patient is breathing spontaneously till you are able to definitely secure the airway. For patient who are little drowsy where you want to avoid intubation, a nasal airway is an alternative. So first thing what we have to remember that airway in operation theater and airway in ICU is a totally different scenario. And why it is so, I'll come to later. But we must know that while the death or hypoxic brain damage or surgical complication, in one of the largest trial from largest database analysis has shown, while mortality rate is 1 per million in a patient who was surgically intubated in a planned way in operation theater. But when it comes to the ER or ICU or away from the operation theater, the risk of this uh, sudden death or cardiac arrest is 1 in 50. Most common cause is hypoxemia, and one of the most important contributing factor is second secondary to esophageal intubation. That means a significant number of patients during intubation in ER or emergency ICU died due to hypoxemia or has a disability, and particularly this happened due to esophageal intubation. We also need to know that a certain group of patients, they are higher risk of cardiac collapse and arrest if they are elderly, they are breathless, if the intubating person is young, has not taken the appropriate training and precaution, has not done enough pre-oxygenation because they do not have any oxygen reserve. This the risk goes to the arrest if BMI is high, we have no oxygenated, and a patient is elderly. One of the most important, this list is exhaustive, I'm not going to read the list, but one of the most important reasons for hypoxic post rapid sequence induction hypoxia or hypotension, we need to remember, and because they are reversible, while esophageal intubation and malposition of the tube is important cause. In cause for hypotension is hypovolemia or raised intrathoracic pressure. And that's the reason you need to pre-hydrate the patient, pre-oxygenate the patient, intubate under vision. And for raised intrathoracic pressure, you need to ventilate them with a low tidal volume more frequently. So these are some issues which we need to remember when we are intubating this patient. As I said that ICU patient poses a challenge different from the OT difficult airway called airway which you can assess, a physiological challenge. And if we start to see the different tidal volume and capacity, the most important uh, issues which you have to remember is the functional residual capacity, particularly expiratory reserve value. This is something which reduces drastically in a patient who are hypoxemic or in hypoxic refractory failure. And because of this low reserve, you do not have that much of time to intubate this patient. This patient needs to be pre-oxygenated well and well prepared. And in less than you can hold one breath. Before that, you need to intubate this patient and secure airway. Not only this physiological change due to respiratory distress, this factor gets further complicated according to the position. If memory is supine, this further FRC further reduces. Elderly has reduced FRC because of the non-compliant chest wall and aging lung. Some ethnic group has, because of the size and because of the weight, has a different lung capacity. As you become obese, your lung capacity further reduces. And if you have a, if your height, if your long or if height is above certain normal, this further contributes. So we have to keep all these factors also in mind when we are managing airway in ICU patient. As we age, our due to the our lung compliance reduces, our resistance increases, as well as elasticity reduces, residual volume increases, but the total FRC is not changed much, but expiratory reserve volume is already low, and your closing lung volume is goes up. All these factors contribute to the more complication when we are managing airway in these patients. If we have to quickly look to that, while the normal breathing pattern of a normal person, when somebody has got increased resistance, that is the peak expiratory flow is less, and when somebody has a problem of decreased resistance but compliance problem, then the FPU1 reduces. What it leads to that to, to generate a certain kind of somebody has to increase transplantation more, and that further leads to the complication. So what I'm trying to emphasize, in different disease condition, patient has a different FRC and spiky residual volume. And this is one of the most important reasons when we intubate this patient for contributing hypoxemia and causing hypoxia and associated brain injury or cardiac arrest. So, depending upon the patient condition, age, you should have certain background knowledge of patient anatomy and physiology. What is the condition when you are going to intubate? And then you take decision. That's why intubation in emergency is a planned, well-trained, and well-approached teamwork. It's not one person job. So critically, any patient has a two kind of difficult airway: physiological difficult airway and anatomical difficult airway. Physiological difficult airway in respiratory distance leads to reduced FRC. Anatomical difficult airway because these patients do not allow you to traditionally assess the airway the way you do in normal patient who are cohesive, who follows your command, and where you can assess and pre-plan. So for us, in acute respiratory distress, all patients have difficult airway, and we have to be ready to follow the cannot intubate and cannot oxygenate protocol in every possible patient. And having so, when we face, we do not have to rush, we do not have to run, other than we are prepared on bedside to handle this situation. So what has been found that in critically ill patients, this one of the largest audit has shown that in generally people are do not anticipate difficult airway because of the poor assessment, uh, uh, the poor planning, and and there is a failure to modify the plan when they come across the difficult airway, anatomical difficult airway. This happened because the poor assessment, poor judgment, and poor anticipation. So, if we go by the assessment method we generally follow in day-to-day practice, as it been taught in anesthesia practice, that do not apply in ICU patient. And even trials has shown, observation has shown that patient who needed the direct laryngoscopy in EI, 1/4 patient were only able to cooperate. 3/4 patients do not cooperate, and it was also found in large study that 2/3 of these patients who developed cardiac arrest, they did not need Malapatti scoring or neck mobility testing, all these things. Rather than they needed something else. So what I wish to emphasize with this observation that when patient comes to any acute respiratory distress, there is something else which you have to do. You have to preserve, and prepare yourself to handle a possible difficult airway rather than going assessing and wasting time rather than giving him oxygen, pre-oxygen, improving lung capacity and preparing yourself for difficult airway. One score, Makocha score, this score has got very good predictive value of around negative predictive value of 98%, but positive predictive value of 36%. Means if you have high score, there is a likely chance that he will have a difficult airway. But the score is low, it doesn't mean patient will not have a difficult airway. This again is a complicated scoring system, but has been verified in ICU patient that higher score has got around 73% sensitivity, 83% specificity, and negative predictive value are around 98%. But positive predictive value is not that high because it's very specific. So when we go to intubate patient in difficult airway, there can be chance that there is a failure to visualize in direct laryngoscope. And most commonly nowadays, visual laryngoscope is being used. Even you can visualize, but you cannot pass the endotracheal tube. And the contributing factor to these are particularly if you're not able to pass airway edema, blood in airway, cervical spine immobility, very obese patient, a small mouth opening. So all these factors can be there, and how to handle this patient without wasting much time, without causing hypoxic injury, we have to prepare ourselves. So preparation for endotracheal intubation, patient positioning, and rapid sequence induction and intubation is the most important step which we all have to master for intubating the ICU patient. There are certain mnemonics which is being used for preparing, but in general, every ICU should have a very well-planned crash cart for managing difficult airway. It should be checked as a checklist, and all the gadgets, right from the suction to the to the to laryngoscope, to LMA, to the buoy, to the direct laryngoscope, and including video range, everything should be ready whenever we want to intubate any sick patient, including invasive and non-invasive device for into ventilating these patients, including medication to prevent the arrest, including medication to hydrate, and including a team if a possible cardiac arrest happens before we call it hypoxic brain injury for good cardiac massage. COVID-19 has also just going airway, different airway management protocol came during COVID for protecting ourselves. But it's not COVID-19. Many times, some of the viral hemorrhagic fever comes, which is highly contagious, and we have lost few of our doctors. So all the patients whom we are going to intubate and we do not know about the nature of disease and onset is sudden, we should always try to protect ourselves by appropriate donning and appropriate using masks and gown and tap. So we should not get infected. And if you are in the mid of any pandemic or respiratory, particularly influenza or COVID-19, better to use at least N95 mask to protect yourself. So always protecting yourself before you go to intubation. I think main person intubating is also important. These are the protocol and these are the kind of covering we have used during COVID-19 initially. Later on, we came to know that N95 mask is 295 and negative pressure is fair enough, and this was removed. So the thing is, you have to have a good team approach and protocol for intubation in ICU. There should be a pre-intubation prepare that contains the presence of at least 2 experienced operators, fluid loading, preparation of sedation, short and long sedation, pre-oxygenation at least for 3 minutes with non-invasive positive pressure ventilation. Many a time in a patient with acute hypoxia failure, if you have given high flow nasal cannula or nasal NIV ventilation, any patient in distress, that can be continued till you prepare for the intubation. But when you remove, at least you should have been prepared with bag mask ventilation because bag mask ventilation always gives you a better control for ventilation than any other devices. During intubation, you should be ready for rapid sequence induction, what it is. There has been a little bit of a controversy and recommendation about the Selig maneuver. Selig maneuver is being used to prevent the aspiration. The risk of aspiration does not happen with everybody, but if patient has taken recently and if you think that patient has got a risk of aspiration, or if neck can be not mobilized, then what can be done that we put a hand below neck, fix the neck, and we give the pressure over cricoid cartilage to prevent the aspiration. There has been a lot of controversy if you think it helps, you doesn't think, but most of the time it is not being practiced until the risk of aspiration is very high and you are preemptive about it. Post intubation confirmation of tube by capnography, though is time demanding, and some of the hospitals do not have. and it's gradually being replaced by handheld ultrasound. How it is, I will tell you. Always ready with norepinephrine, and in fact, bolus short-acting norepinephrine and phenylephrine are also being used in some of the patients who develop hypertension just to prevent the cardiac arrest in these patients. Post-intubation, a maintenance of sedation and protective ventilation is important. The first thing about the position. When we intubate this patient, there has been always a uh, 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 fight or discussion about what kind of position is RAM position or sleeping position. I personally prefer a sleeping position, which gives me a direct access to the trachea and better visualization, where there is a flexion over cervical and there is extension over atlantic occipital band. You have to be very, very careful. This when you are giving this position in patient who has got head injury, trauma, and suspicion of cervical spine injury. This position cannot be made in this position where you have to keep the neck flexed, or you have to immobilize the neck. You need a difficult. So whenever cervical spine injury comes, it itself challenges the intubator with a difficult airway. But the first thing, otherwise, in all the patients, sleeping position is a preferred position for intubating patient. And this is a fluoroscopic view of how the cervical spine moves when you maintain a sleeping position. If patient has got cervical spine injury, you need to maintain an inline axial stabilization. Here, select maneuver is needed to improve the visualization of the cord and helping intubation as well as preventing aspiration. You also need to give IV anticholinergic to prevent cardiac arrest due to vagal tone, because cardiac arrest during cervical spine injury is very common due to high vagal tone. So, if you have a cervical spine injury, as I said, that inline in stabilizer intubation, preferably under direct laryngoscopy, is preferred, even wheezy can be used. So, what we need to do, that we need to give, till we are ready for intubation, we need to give it enough pre-oxygenation. Why enough pre-oxygenation? Because all these patients have got reduced FRC. You need to preferably use BMB, but there has been like thought also that you give diaphragm ventilation versus no ventilation. But when you do that, risk of hypoxic brain injury high in a patient where ventilation is not there. So all the patients who are less than 50, who are done by the non-trained person, uh, raise, and if the cause for the hypoxic intubation is hypoxic respiratory failure, if saturation is less than 94% to begin with, and BMI is high, all these patients has high risk of high risk of intubation, high risk of intubation, hypoxic injury, intubation failure, and we need to be careful. So all these patients need to be given enough pre-oxygenation before we start intubation. Pre-oxygen modality, non-invasive positive filtration versus HFNC. HFNC and even HFNC can be combined with non-invasive positive filtration. Post-intubation, recruitment maneuver has also been done to prevent the hypoxemia, but due to the respiratory distress and due to the reduced FRC, this patient has kind of physiological atelectasis, and we need to do the recruitment to improve the hypoxia. As I said, select maneuver does not prevent aspiration, may delay intubation, should not be practiced routinely. We have to use the optimal use of pharmacological agent for avoiding coughing, avoiding farting, and relaxing airway completely, so we can visualize airway and intubate. But when we are doing that, we have to know that patient is totally dependent on us for ventilation. So we need to ventilate properly, we need to oxygenate properly, and after that, in one go, we should try to intubate this patient. Most of the time, because this patient has hypotension, until there is hypertension and cervical, there is traumatic brain injury. Otherwise, intermediate or if patient is hypotensive, ketamine remains the of choice for induction. Even fentanyl also can be used for induction. But it is most important that nowadays rocuronium is replacing succinyl choline, because succinyl choline has got high risk of cardiac arrest in a patient who has got hyperkalemia, where you don't know the status of the particular potassium. So just to avoid that, rocuronium is very safe. Only thing we have to remember that the dose of rocuronium for induction and helping intubation is 1.5 milligram per kg to get the good result. All these medicines are short acting, and most of them the effect goes off in 2 to 3 minutes, and that's where if you fail to intubate, at least you can oxygenate them for 2 to 3 minutes, and that's precisely the reason we do not use any long acting drug. So we need a drug where onset of action is short, immediately, quickly, and the effect lasts for 2 to 3 minutes, not more. One of the important effects that to always remember that myocardial suppression, reduction in blood cerebral blood flow, internal pressure, cerebral blood flow, and even oxygen is an important issue with all these drugs. And that's precisely the reason uh, we have to always pre-oxygenate, give enough fluid, always keep a sort of the short acting noradrenaline or phenylephrine with us, depending on the develop. And then when we induce, we have to always ready with monitoring of with this measure. As I said, push those vasopressors should always be ready and should be part of our crash card when we are going to intubate this patient. Phenylephrine has to be used if patient has hypotension with tachycardia, and if patient has hypotension without tachycardia, then epinephrine remains the best of choice. Normally, we don't have to give more than like 100 microgram per ml dose or 10 microgram per ml dose, and like 1 to 2 ml dose, like 100 to 100 microgram of phenylephrine or 10 to 20 milligram or 30 microgram of the epinephrine is enough as a pushover dose for the person. So, what is the current concept in tracheal intubation in ICU? First thing about the what recently has been seen that most of the ICU are replacing direct laryngoscopy with video laryngoscopy. Direct laryngoscopy, the advantage of video laryngoscopy that at least you can visualize the epiglottis and opening clearly, but it doesn't. It's not. It's a time consuming, and it needs appropriate training of the person. If it is not so, then because most of the time the newcomers are trained with direct laryngoscopy and video laryngoscopy, they do not have access. This can sometimes create problem in first pass attempt, and they fail to intubate. And even during intubation, if they cause any trauma of upper airway, that can complicate the issue further. And this is more common in a patient who come to us with a medical condition, particularly if they have sepsis, DIC, or multi-organ dysfunction. So, as with any procedure, if you are too much interested for video laryngoscopy, you also need to train and follow the appropriate protocol for this. So, how we intubate? We head up the patient position, particularly not in, particularly I prefer sleeping position. Working equipment should be ready. Though there is one main operator, there should be always a backup of the second person. You should have all the gadgets to handle difficult airway, including the cricothyroid. Handheld ultrasound is nowadays a good help for managing difficult airway in ICU patient. You need to go for the, if you can do the scoring system. And during this time, while you are preparing yourself, you keep on oxygenating, prepare yourself, keep on oxygenating, hydrate them well, induce them, monitor them well, everything should be ready. And if the score is less than 3, direct laryngoscopy is good with the help of stimulate or malleable tube. If score is more than 3, the video laryngoscopy is a good option. What is the most important thing that once you have intubated the patient after immediately intubating, you need to confirm the tube. So if capnography, for successful intubation, capnography is the best tool. But nowadays, if you have handheld ultrasound, you can confirm with better sensitivity and specificity with handheld ultrasound that you are in trachea. Not only that, you can even confirm that you have gone further or you are at appropriate place. So handheld ultrasound is gradually replacing the even capnography for confirming the tube position and even positioning of the endotracheal tube. This is how the capnography will take 1 or 2 breaths before you can see or you have to connect the patient to the ventilator. But what you get in ultrasound, that when you are in trachea, you can see the tracheal ring and you can see the tube, there is a gap, and there will be only one one sign. But when you go in tube, the tube will appear here, another black dark hole or dark aperture appears. So when you have second dark aperture, double halo sign appears, that means you are definitely in esophagus. You immediately need to remove. So this you are doing online while intubating. You don't even need to connect for the endotracheal ETCO to confirmation. Unless you have confirmation, connected the ETCO to into online, this is also time saving, and in time it tells you that you are in wrong position, you need to adjust your tube. And that's the reason handheld ultrasound is gradually replacing the ETCO tube for monitoring the positioning of the tube. Apart from that, with handheld ultrasound, very quickly we can also assess the difficult airway. We can also assess the cricothyroid membrane surgical and we can identify and appropriately puncture it, and we can even prevent the aspiration rate just looking to the stomach content, and we can do the salic maneuver to prevent that. One of the important thing about the finding the difficult airway, although it's in pilot phase, but skin to epiglottic distance is more than 30 millimeters. It's one of the very high predictive of the difficult airway in a patient with respiratory distress. So probably ultrasound is going to help us in more and more. As I said, that intubation is highly related to the human factor and team behavior. So repeated training, appropriate team builder, repeated training with the and certification by different agency is one of the key factors for reducing the complication related to airway management and issue. So what happens if you cannot intubate or cannot oxygenate? It's called SICO rescue, and the vertex approach is being proposed for it. Initially, you give bag mask ventilation. You try to intubate with airway. If you are not able to do it, again you take on bag mask, again try, but do not attempt more than 2 times. In the meantime, you call for better help. And if you have failed 2 times, better to go for the laryngeal mask airway, oxygenate the patient well, get better person to come, prepare yourself for the managing difficult airway, till that you do not compromise with hypoxia. What happened during this time, we try to intubate so desperately that we forget to use LMA, and we forget to use that we can even oxygenate without intubating the patient without causing further damage. So if we just remember this vertex approach for the patient where we find that the airway is difficult, we are not able to visualize, other than causing trauma, injury, bleeding, and making the airway difficult, we should try to oxygenate, equip ourselves better, get better person on site, and even prepare ourselves for surgical and surgical intervention. And if we cannot intubate and cannot oxygenate patient, then cricothyroid, mini cricothyroid, pumping the cricothyroid membrane, the cricothyroid shape, or even with needle, and oxygenating through that, jet ventilation or through oxygenation is the other option for securing the airway. This is how you secure the LMA and oxygenate the patient well. Many a time you come across with condition where you should not sedate the patient, because the moment you sedate, you take away the breathing efforts of the patient, and the likely the patient will become hypoxic and die. Particularly if patient has very severe cervical spine injury, very severe, there is a mass in like fixed cervical spine due to the ankylosing spondylitis. There can be case of the big thyroid goiter and thyroid disease, a very obese patient where neck is not visible, and unstable cervical spine. These are the patients who even can be tried with awake intubation, with intubating ground, or with the help of local application of anesthesia. So we should also remember, and particularly patient is developing stridor. These are the patients, if you try to sedate, the moment you sedate, they will arrest because um, uh, their airway will collapse, their vocal cord will collapse, and he will not able to even pass through that. So particularly in patient who has got stridor, we should not try to sedate or paralyze, rather than try to do awake intubation. So this is how you do the awake intubation. With even nasal intubation can be tried with enough local anesthesia. just put a railroad endotracheal tube over bronchoscope and go through the nose, railroad it over and pass. What is our goal to achieve? What is our goal? The goal to achieve 100% perfection, because we know that the risk of hypoxic brain injury or brain death or cardiac arrest is very high if the intubation is not appropriate. So no hypoxic injury. We should have first pass intubation, success rate 100%. That's what ideal goal, and 100% physiological optimization. That's what we want to achieve in intubation. So with this, thank you. Thank you for your attention. I have taken appropriate time and I have been taken.
Thank you very much. Thank you very much, Dr. Rajesh Mishra, for this outstanding lecture. And I can see that the feedback is extraordinary, really. Now we know why you're the president, the new president in the